Hello everybody, I am Nandakishore Setti from GAMAN Health Center, an integrated wellness and interventional rehabilitation facility. Today we are going to talk about post-COVID rehabilitation. Our team at GAMAN Health Center fought hard and fought bravely, and our team, even when they personally got affected, when they were admitted in ICU, they are recovering as well as helping other patients to recover while supporting their colleagues. So, while discussing about the COVID scenarios, what they have done, how it helped patients, and how we should prepare ourselves for post-COVID rehabilitation aspects, how to help the patients, those who are out of acute setups but still fighting it and finding it hard to recover from the COVID impact. So let us have those discussions today. Today I have Shyamna Sri, our senior physiotherapist.
Namaste sir, this is Shyamna Sri, working as a physiotherapist in GAMAN Health Center.
Jaimol, our respiratory therapist, and Anushri, our senior physiotherapist.
Namaste sir. This is Anushri Chidurala. I am a physiotherapist at GAMAN Health Center.
With me. Thank you for coming today. I would like to start with Jaimol. Jaimol, you yourself got affected with COVID.
Yeah, yes sir.
You were admitted in ICU.
Yeah.
And rest of the day you are in ICU. What is the difference between that ICU when you admitted as a patient and when you are helping the patient to recover?
It was such a fantastic experience for me because being as a COVID patient, I am coming for doing duty or how much I can help for others to recover from COVID. I feel very happy because being as a COVID also, I am also having 101, 102 temperature. With that also I came here to help the patient. I feel very good because in being as a sick also, I can help others. I feel so good.
So that feeling helped you to recover quickly.
Well, yeah.
After recovering, do you feel like running away or you want to stand and fight again?
I never thought of running away from here. I thought of fighting here only against COVID. To how much I can help to patients, that much I can do. I thought like that because I also came from the same situation. So I feel like I know the pain, I know the all kind of things, what are the things COVID patients are facing. So I thought how much I can do for them, I can do it.
Fantastic.
Thank you.
And your fight and your service will be remembered for a very long time. Like as a respiratory therapist, what was your primary role in ICU, especially when a patient is on ventilator?
We used to be in ICU most of the time, sir. So when patient is there on ventilator, we are taking care of the, first of all, we used to give preference to the ventilator parameters. What are the settings we have given to the patient, how much we set into ventilator, how much patient able to take and how much patient is generating. That we are under respiratory therapist only, we are only taking care of this, all those things, and also how can we reduce the FiO2 or how can we reduce the all setting of parameter from the ventilator, and also to protect airway. How can we protect airway, especially when patient is there on for invasive ventilation, in the sense we can go to either tracheostomy or endotracheal tube, we can which is going to mouth into the airway direct. To prevent airway, we can go through chest physio. After chest physio, we can go through suctioning, deep suctioning we can do it. By the help of that, with the help of suction apparatus, we can remove the all secretions from the lung. They can control their self and also they can improve themselves. And also we are ABG interpretation every second hourly or fourth hourly is must. We are only handling the all ABG machines also, and also ventilator, BiPAP, all those things. After taking ABG, we are doing the all pH values, PCO2, how much patient is getting, how much, what are the settings we can change, what are the things we can do, all those things. Oral hygiene, bronchial hygiene is very must, which are the patient either on tracheostomy or ventilator. For tracheostomy patient, which is the patient on ventilator with the tracheostomy care is must. We have to keep on doing tracheostomy care twice in the day. And also tracheostomy care, tracheostomy dressing, tracheostomy suctioning, all those things with the help of chest physio. After chest physio, we have to go through suctioning, deep suctioning, parameters, vitals of the patient, how much patient able to take FiO2, how much we are setting into ventilator, and along with that how much patient is generating the SpO2. Depend upon that, slowly we are coming down to FiO2, then we can come to know how much patient is generating, how much tidal volume patient is generating, and also how fastly patient is recovering from the ventilator, and how fastly we can wean off, and slowly we can there will be a different type of modes of ventilation, like assist control with the volume control and pressure control, and next is SIMV, synchronized intermittent mandatory ventilation. Slowly we can reduce the settings and we can go through.
Jaimal, please tell me, in a COVID scenario, the ICU in COVID scenario is different from any regular ICU. There is a method behind madness, but in a COVID scenario, there is no method whatsoever, and who is coming, who is recovering, who is getting deteriorated, who needs maximum attention. Suddenly you find somebody and they recovered well, they discharged, and suddenly somebody is on. It was kind of a breathless situation and energy draining. So what is your motivation when you are having multitasking, multiple setups? One side you have ventilators, another side you have NIV, another side you have HFNC, and irrespective of the age group, more complications, different setups, everybody needs attention. What helped you to focus so that you can help the patient to recover?
First of all, we'll give preference to ventilator patients. I mean, which are the patient unable to take breath there as their own. So either in case of any cardiac arrest or respiratory arrest, or if any other problem, in which are the situation they unable to take their own breath. So we'll go through intubation, then we'll connect it to ventilator. Why? Because that patient definitely which are the conditions is going through the ventilator, we able to understand. We'll give, first of all, we'll give priority to every patient. So we'll go through ventilator. Ventilator is the mechanical ventilation that will give artificial mechanical breathing to the patient, which are the patient not able to take their own breath. So that we are doing, that I told you before. What are the settings? If patient not able to, when they are not able to take their own breath, we'll go through assist control. Our volume control depend upon the patient condition. We'll go through ventilator setup. Then coming to NIV is like they are giving that device is giving help to the patient to take their breath, to supporting to the patient. Patient can take breath, and also they are taking double breathing. Their respiratory rate will be high. So we need to give some support to the patient. So we are going through NIV. NIV also different type of devices are there, like BiPAP, CPAP, NIV. NIV is we are connecting to face. I mean through mask we are going through ventilator. That is called NIV. So, and coming to BiPAP is also separate one small machine that we are giving additional air to the patient lungs. So that in that BiPAP there will be a two pressure, one is IPAP and one is EPAP, that we can depend upon the patient conditions, we can set to that. And if comparing to in the COVID patients, we can't able to tell anything about the patients before we can judge, because which are the condition we are coming through, immediately action will be. So when which are the patient is on ventilator, always give preference to supine position and proning position. That will be the must. Why? Because when patient will be on supine position, their alveoli abduction will be there. So to decrease that, we used to make him from supine position to prone position. Proning, we respiratory therapist will be there in the head position, because we are only handling the all, if patient is there on tube, I mean ET tube through mouth, or tracheostomy tube through trachea. So we are handling the all those things, which are the patient is there on ventilator. So these things are we are doing. And also like in the ICU, normal who need normal oxygen therapy, that also will be there. Who need more than 10 liter to 15 liter oxygen, if any patient need, that will be a device called high concentration mask, that we can go through that. It will give up to 40 or 50% of FiO2 to patient, which are the patient need very less oxygen. For them, the device is normal face mask or nasal prong. In the nasal prong is like lightweight tube, which in the end of the side it will be separated to the two prongs, that will be directly goes to the nose. That will give the 1 liter oxygen, which are the patient is taking 1 liter oxygen. It's called 24% of FiO2 patient is delivering. If patient is there on 2 liter of FiO2, 2 liter of oxygen, the FiO2 will be 28. That is the thumb figure further. We are ruling out the old patient from how can we wean out from the ventilator, or how can we wean out from the BiPAP, or how can can we take out the oxygen from the patient. This all the things we are doing, and also which are the patient is their own oxygen therapy. We can go through spirometry technique, we can go through aerosol therapy, and also chest physio, suctioning. For tracheostomy patient or intubated patient, we can remove the secretion from the lungs with the help of suction apparatus. But who are not in ventilator or NAV and who required oxygen and who are on nasal prong or high concentration mask, we can't take anything. There is no any other option for taking secretion from ET tube or tracheostomy. To improve his lungs expansion, we can go through chest physio, spirometry, then we can go through suctioning also. This is the things we are doing. And one more thing, when patient is there on nasal prong or anything, nasal prong with for sure humidifier with the NS or sterile water should be, because otherwise directly the oxygen is going through nose, nasal bleed can happen. So to avoid that, we should not normal water like NS or distilled water, we should add in that flow meter, then we can connect oxygen.
Humidification will be done.
Oxygen
Fantastic.
with the humidification will be there.
So much to do.
Yeah, yes.
Well done. For a brilliant critical care team, they need these wonderful respiratory therapists, a physiotherapist, and exceptionally trained nursing care team to get the desired results and to help the patients to overcome. And this is what I personally feel the young India needs. These kind of specialities must brought into limelight. The amount of service they have done must be recognized. The bravery they have shown should be appreciated. Thank you, Jaimal. Thank you for being there. Thank you for being with GAMAN during these COVID pandemic situations. It is a joy. Thank you.
Thank you.
Next, Anusri, you bravely worked in COVID ICUs. You guys are one of the very first to voluntarily join the force, wanted to help the patients. You personally chosen to support patients in the most critical situations. What was your experience? Why you chose that special group?
Actually, I was so interested to treat the COVID patients. I was very thankful to you to give this opportunity. The patients who were suffering with COVID,
you wanted to help them
I wanted
to
to help
recover.
them. Yeah.
So your challenge, prevent complications and to help them get enough oxygen. So position changing is the key, right? You have to put them on supine, in prone, side lying on either side. When they are connected with so many tubes, pipes, what is the need for changing those positions? This is for people to know.
Actually, position plays a major role in the patients. Like it involves the proper alignment of the body to maintain the oxygenation and to improve the ventilation perfusion ratio. Before treating the patient, we should monitor the patient vitals. The BP and heart rate is either normal or not, and transitionally for every 30 minutes to 1 hour we should change the positions to prevent the complications. For common rest, patients will be in ventilation, so they may develop the complications like bed sores and contractures. To prevent that, physiotherapy plays a major role. To prevent the contractures, we used to give the passive movements, and to prevent the complications like bed sores, we used to maintain proper bed like 8 beds, and positioning is must. If the patient was in Ryle's tube, we used to maintain the bed as inclined up to 20 to 30 degrees, so we can prevent the complication like aspiration pneumonia. Proper positioning, like when the patient was in lying, we used to take up to the sitting. That means bed inclined up to 45 degrees to 90 degrees. It can maintain to not create the contractures, and supine lying and prone lying and side lying is also must. If the lung secretions are developed, we used to use the technique chest physiotherapy like percussions, shaking and vibrations. This technique can be given in supine lying, prone lying and side lying, so that the secretions can come out through the cough or huff. For that we have the FET technique, forced expiration technique, and we also teach them coughing and huffing technique. Through that the secretions come out. Otherwise we suggest the respiration like suctioning therapy.
When you have 10 to 15 beds,
Yes, sir.
so you have to keep continuing one after the other, right? By the time you finish, the first individual's time is there, right? It is a strenuous, continuous job. Where did you derive that energy from?
I loved, enjoyed by treating the peoples in ICU, by introducing myself as a physiotherapist, and I supported the people to not get depressed, and supported the people and encouraged.
It's a team effort, isn't it?
Yes, sir.
So yourself, a respiratory therapist, nursing team, paramedics, duty medical officers, an entire army,
Yes.
and that the team lead is a critical care consultant. It's an army. How many people are needed when you are proning somebody who is on ventilator?
It takes 6 people, sir, like one respiratory therapist, one physiotherapist, 2 or 3 nursing team. It helpful
And
to
a duty medical officer and a critical care consultant.
Yeah, sir.
So every time you are positioning, but that is on your call. So fantastic, fantastic. Thank you.
Thank you, sir.
Thank you. Shyamna,
Yes, sir.
thanks for joining today. You are the key partner in your ICU physiotherapy team, and you personally took the responsibility of preventing pressure sores
Yes, sir.
in long COVID patients. Right. The incidence of pressure sores in patients who are staying in ICU for very long time is extremely high. And the challenges of preventing a pressure sore, even if people recovered from COVID, they are getting into so many other problems with the pressure sore, infections, abscess developments. So preventing pressure sores in ICU setups, especially in COVID, is a very complex task. I wanted to hear from our senior physiotherapist Shyamana. She took it as a special challenge in preventing pressure sores at GAMAN Health Center. What was her plan? How she executed? What are the precautions she has taken? Let us hear from her. Shyamana.
Okay, sir. First of all, bed sores or the pressure sores is seen on the skin or the soft tissue where there is a prolonged pressure over the skin. And these are seen most commonly on the ischium or occipital area, sacral region, and ankle malleolus region. And when there is a prolonged pressure on the skin, there will be the occlusion of the blood vessels, capillary blood vessels. When there is a occlusion, the air supply will be decreased. Due to the decreased air supply, ischemic changes will occur, and due to that, necrosis will be formed. When it is undetected or neglected, it may leads to cellulitis, and unhealed wounds may change into cancer, and sepsis may form. So there will be different stages in bed sores. Stage 1 is the erythema, and stage 2 is the tissue rupture, like there will be loss of tissue including the epidermis, and stage 3 subcutaneous fat is exposed, and in stage 4 bones and joints will be infected. These will be infected. And while coming to the COVID patients, due to the prone position is generally given to increase the ventilation in COVID position, so that due to the prone position there may be a chances of developing pressure sores over the face. In order to prevent that, we take different preventive measures like a position change for every 2 years, especially skin hygiene, position change, and placing cushions over the bony prominence area. And the medical team and the nursing team, they will take care of the antiseptic powders and antibiotics, and if any dead tissue is there, they will go for surgery. This is the main thing. And it's not like one-man team. It's not like a one-man team. It's a teamwork where the nurse, respiratory therapist, physiotherapist, duty doctors, and critical care unit, everyone will be involved. And here in GAMAN Health Center, we got the very good team, excellent team, where everyone, I personally appreciate for their dedication and hard work. And I thank Dr. Nandakishore sir for giving me this great opportunity. Thank you.
Shyamana,
Sir.
especially in COVID, we have patients with uncontrolled sugars, raised inflammatory markers, high temperatures, dehydration, compromised nutrition. So the natural incidence of having pressure sore is getting high. So how you guys coordinated with your nutrition team, and what are the special precautions you got in terms of preventing pressure sores? How regularly you did the passive mobilization? How regularly you have to do those position changes, did you have any system to classify like these guys are more prone for pressure sores, these guys are okay, they are relatively mobile? Do you have any plan, or on what basis you judged that these guys are pressure sore prone? And first question I would like to really know, how many patients in the last 3 months under your care actually got pressure sore?
Okay, I'm happy to say that we never got the patients up to like grade 2 pressure source patients here. It's up to grade 1 only, and we never neglected. Early detection is important for pressure source. We did, our team inspected every area every day. They did it very well without worsening the condition. 3 months we never got the patient with grade 2. And we prevented it with all our team, like nursing staff, respiratory therapist, dietitian, duty doctors, physiotherapist, by changing the position for every 2 hours, dressing, proper skin hygiene. These are the precautions we took for preventing the pressure sores.
Fantastic, good job, good job.
I am very thankful to Dr. Nandakishore sir for giving this opportunity to treat the COVID patients. I had a very good experience here. I am very glad to be here as a part of GAMAN Health Center. Thank you.